And good afternoon, everyone, and thank you for joining. I assume I can be heard all okay. We're looking at targeting maternal patients regarding safety recommendations in venous thromboembolism and their risk factors. This slide is certainly worth looking at again, the CDC data on pregnancy-related mortality ratio. In the U.S., you can see a relatively steady climb. Back in 2003, so now about 10 years ago, is when we started using the new death certificate, which was slowly adopted over the last decade in different areas and still is not in all states, but does have a specific indicator to identify patients who have been pregnant in the last year. Not surprisingly, since it's specifically related to the half of pulmonary embolic events that occur, including the deaths postpartum, these patients can present to non-obstetric providers. They may not identify the patient, therefore, as having a pregnancy-related death. So it does indicate that there probably was an increased capture as one of the results, but certainly the steady climb in maternal mortality over the last 25 years identifies this as a significant issue and not only related to data capture. A number of reasons why this may be occurring, particularly related to overall deaths as well as venous thromboembolic related deaths. Probably the most important line on here is the bottom one that just came in, which shows an 8-fold increase in the maternal age group 35 and older in the last 30 to 40 years. And not surprisingly, just like with all of us, as we age, underlying diseases tend to present themselves, particularly related to pregnancy, some things where patients may have traditionally been managed with decreased activity or even bed rest, things like chronic hypertension and the increased risk of preeclampsia associated with that, all of which may and is certainly related to the development of venous thromboembolism as an important cause of maternal death and severe morbidity. Of course, an important contributor to that has been the operative delivery rate. We know that's gone up over 50% just in the last decade and about 60 to 65% in the last 15 to 18 years. We don't need to dwell on that. We're aware of it, but surgical intervention, particularly related to obstetric patients who already have a 4 to 5-fold increased relative risk of thromboembolic phenomenon, the addition of the surgery only increased that risk. From a gynecologic standpoint, when we look at surgery alone, we know that about literally, this always surprises me when I look at it, in non-prophylactic patients undergoing significant gynecologic surgery, 15 to 40% of them develop a DVT. So it's not surprising the risk factors are there and can be translated to the obstetric community with the increased rise associated, the increased cesarean section rate, surgical rate that we've seen. Dr. Clark has looked at this as well, particularly related to the relationship between route of delivery and maternal death, and this refers back to the Joint Commission on Sentinel Events, the alert issue number 44, where he reported this initially. And you can see there's roughly a 10-fold, and these numbers are risk of death related to route of delivery. So you can see this is roughly a 10-fold increased risk of death related to primary cesarean section and about 5-fold related to repeat. Generally, those are unlabored. So the total cesarean section increase, you can see, is about 6-fold total, 5 to 6-fold total. And if we look at the cause of death, specifically related to the issues we're talking about, you can see where thrombotic pulmonary embolism lies on that trail. Of course, venous thromboembolism, which we'll talk about in a moment, it's the combination of DVT and PE, but thrombotic pulmonary embolism is about 10% of all maternal deaths. It's been identified as high as 20% in some states, depending on the demographic population. That is 20% of all maternal deaths related to embolism. But you can see cardiomyopathy, hemorrhage, hypertensive disorders in pregnancy, and pulmonary embolism are very similarly related around that 10% range. We look at the related mortality, again, getting back to Chang's data as well. we see that all causes of pregnancy outcome and pregnancy-related mortality ratio, embolism is as high as 20%, as I just mentioned, in the 10 years of the 1990s, which is actually a relatively recently reported issue back in, although it is a decade old, back in 2003. But again, it gives you an idea of the cause of maternal death, particularly related to different areas of the country as well as in countrywide. Infection has been, does fluctuate, has been somewhat decreasing, although in England they have identified it in the Why Mothers Die evaluation as being the most common cause of direct maternal death. Looking back at all causes from maternal death just from New York State, we found a similar data pool in that about a quarter of maternal deaths related to embolism. That also included amniotic fluid embolism in that population. It wasn't separated out. Getting back to Dr. Clark's data, if we look at the direct causal relationship between route of delivery and maternal death, and I'll show you why we're looking at this specifically in a minute, we can see about a 10-fold increased risk for primary cesarean section rate and about a 5-fold increased risk for repeat cesarean section rate. Overall total cesarean section rate relative risk is up substantially and significantly. Interesting, however, if, as Dr. Clark did, if you back out the venous thromboembolic deaths in these subgroups, we begin to see actually at the end of it, a non-significant difference both between vaginal and primary cesarean section, again, just in this population group, and between vaginal and repeat cesarean section. And overall, the data pool showed a non-significant difference between route of delivery and maternal death when you excluded pulmonary embolism. In other words, if we were perfect in our prevention for venous thromboembolism and pulmonary embolism, we may see a dramatically different overall risk associated particularly with our operative deliveries. And not surprisingly, with about 4 million deliveries a year, about a third of which is cesarean section, we have about 1 1/3 million cesarean sections a year. And on that number, nationally, even low incident outcomes become important. So even if you don't see it as an individual provider, or you don't see it as a hospital-based data pool, you very well likely see, as they're seeing it on a state basis in New York, but certainly on a national basis because of the number of deliveries that are done annually. And we have the ability to gather this data now because of the combined efforts of all the data pools and states coming into one. It's important to touch on definitions when we move toward prevention. Deep venous thrombosis, we're familiar with, is a blood clot in the deep venous system, generally the extremities. Pulmonary embolism is as it sounds. It's when a thrombosis actually cleaves off and moves into the pulmonary arterial system, such that deep venous thrombosis plus pulmonary embolism equals venous thromboembolism. So we cannot use these terms interchangeably, as you can see, and it's important that we keep our mind focus important and focused, mainly because it's generally not the DVT that's the issue, but it's the pulmonary embolism that's the issue, particularly from a mortality basis. And only a % of patients actually have a pulmonary embolism who have a DVT, but it is the DVT level. If we cannot prevent the DVT, we need to prevent the pulmonary embolism, which is what treatment does. In addition, adding to that, a significant % of patients actually don't present with complaints of DVT and go to direct pulmonary embolism. And an important number two is that patients who get a pulmonary embolism who end up dying do so generally within about 30 minutes. Therefore, we don't have the ability, or we have a limited ability to treat once a mortal pulmonary embolus event starts, such that we really need to move back into the prevention phase. And since a good percentage of patients don't present with direct complaints of DVT, we really need to be preventing the initial DVT. Just thought I'd throw in a picture of a DVT. Again, we're familiar with that. That's why we have clinical pictures of it. But for pulmonary embolisms, we only have a schematic because it's not something we always see, we can see at all clinically looking at the patient. But it's a clinical presentation that defines the PE, both from a clinical evaluation and laboratory evaluation standpoint. The incidence of venous thrombosis, about 1 to 2 per 1,000 pregnancies. As I mentioned, 4 to 5-fold increased risk related to pregnancy. And importantly, half of those occur during pregnancy and half postpartum. So while there is a markedly increased risk associated with the pregnant state, probably mostly in the 3rd trimester, it looks like the significant risk period is in the immediate postpartum and the immediate postpartum period, so that we need to be aware of that as well, especially when we're talking about evaluation for prevention. And generally, a little more than 1 out of 100,000 maternal deaths are related to this, roughly 10, and as you saw from the New York State data, as high as 20 to 24% of maternal deaths maybe have their direct cause related to pulmonary embolism. Risk factors are important, and this gets down to our evaluation piece. Prior history of venous thromboembolic disease is quite important. We need to be quite aggressive and appropriate. We need to use a checklist or something that gets us to the heart of the history and getting this history from patients because of the substantially increased risk associated with this prior history. Of course, the different thrombophilias, I know the data is confusing, but generally the 3 main thrombophilias need to be evaluated within a family basis as well as within an individual basis, particularly if they have a history of venous thromboembolism. Of course, other issues that increase risk, about 2 to 4-fold roughly, bed rest, obesity, smoking's on the list, and of course operative deliveries, as we all just looked at that data. Some, however, are already preventable. You might say that obesity is somewhat preventable if patients can be seen prior to the pregnancy in the standpoint of consultation, but we all know the difficulties across individuals as well as across populations of altering body habitus. Bed rest, on the other hand, back in 2003, ACOG had this statement on bed rest and hydration for patients with symptoms of preterm labor as used to potentially prevent preterm delivery. That very important, bed rest has not been shown to be effective and should not be routinely recommended. And this lets us go back now, 10 years after these statements, and talk to our individual providers, since again, this likely mostly occurs as an outpatient. Make sure we're all up to snuff, if you will, on this data point. And of course, they go on to say that furthermore, there's potential harm associated with bed rest. For this indication, there are some reasons to decrease activity, but ACOG does not feel this is one of them, and venous thromboembolism is an important risk factor, among others, but it's the most potentially mortal of them all. Of course, cesarean delivery and operative delivery is important. Essentially, every patient is in moderate risk. The only exceptions to that would be patients who have surgery lasting less than 30 minutes, who are under 40, who have no other risk factors. And quite frankly, if they do come out as low risk, number one, pneumatic compression devices are not going to do them harm. And number two, if we try to separate out these patients, we may end up missing patients, which is going to do more harm in the long run. Finally, I would make the argument that really no patients are low risk. I'm sure there are cases of cesarean sections being done in 20 minutes. You always hear about that, and we always hear the bragging among our residents about that. But the reality is that the clock really starts ticking at the initiation of anesthesia, and if you take that into account, there's really no case of a patient in the low-risk category undergoing cesarean section in which it lasts less than 30 minutes. And we'll get more into that in a moment. So the 3 important triggers, as we said, because death can occur rapidly when it's going to occur with pulmonary embolism, despite our treatment, and we can't always identify patients with deep venous thrombosis, that we really need to get into the prevention mode as well as the recognition and treatment mode. But prevention is the big hook to stop the initial event, as we saw with the perfect prevention experiment in Dr. Clark's data. We can actually markedly reduce the increased mortal risk associated with both primary and repeat cesarean section with perfect prevention, if you will. What is prevention? The 3 underscores for prevention are the risk assessment. and the importance of doing it carefully and thoroughly, identifying them as risk-appropriate prophylaxis, and the fact that make sure our systems are set up so once they are risked appropriately that they actually receive the prophylaxis as indicated, and then repeat that. Repeat that not only at the initial contact with pregnancy, but it's reasonable to initiate it, to repeat that in the third trimester, and then again add admission to the hospital, and then some could even argue repeat it again in the immediate postpartum period so that patients understand if they need to continue. So you, providers, need to understand, and the system is set up to continue care as appropriate. So initial visit during the pregnancy, generally as the patient approaches the third trimester, and again at admission for delivery, and some might add again in the postpartum period, just so clarity is there. For effective risk assessment to occur, you're really trying to put patients in different risk categories. As I mentioned, the low-risk category, I have decided really doesn't exist in the cesarean section population, so that really puts the vast majority of our patients in the moderate and high-risk population group. And the highest risk population essentially always comes in already on some kind of venous thromboembolism treatment, and all we need to do is figure out how to work around that treatment to get them surgery, number one, and then number two, make sure they continue the therapy appropriate for their medical condition. So they stand out for that reason, and that's the smallest % of the population. So that ultimately leaves us the vast bulk of patients going to cesarean delivery in the moderate and high risk category, essentially, as I say, because the low risk category doesn't exist, and the high risk category already presents substantial blood thinners of some types, but some prophylactic measure. Effective risk prophylaxis assessment is going to lead to appropriate risk-based therapy, which really comes down to all patients with cesarean delivery having pneumatic compression devices placed prior to surgery. How do we get this? Well, the low-risk patients, again, I kind of take off the map. It's hard to say they really exist. So you get moderate and high-risk category where pneumatic compression devices are adequate therapy for the peri-surgical environment. And the highest risk group, who are going to generally end up being combination therapy, are going to get pneumatic compression devices as well as usually some kind of heparin-based prophylaxis. So essentially, all patients will be candidates for pneumatic compression devices. Again, it's worth saying again from a prevention standpoint, doing appropriate risk assessment, putting them in the moderate, high, or highest risk category, giving them risk-appropriate prophylaxis for every patient. That includes pneumatic compression devices in the operative theater, placed prior to surgery and continuing, and then repeating that assessment as appropriately during the course of the pregnancy, not only at the initial visit, but at the second visit, at the beginning of the third trimester generally is a good time to do that, to revisit those important issues, and then at the time of admission to labor and delivery, and then one could argue in the postpartum period. So those are the drivers that are trying to be addressed with the different visits to, you might call them a checklist or some tool that can be used, as you can see.